Well, we want to welcome everybody to lunch, and we'll just kind of sit here and watch you guys eat. No, we're grateful to have two really important guests today. I'm thrilled to have the honor of being able to moderate this session. I'll just introduce myself. My name's Scott Pingree, and I work with HMA. I'm a managing principal in that office. It's my great privilege to interface with leaders such as Margaret and Tracy, and I'm just really thrilled to be up here with them today. And I thought this would be a really interesting session while everybody's eating, just to talk through their two organizations here in the state of Utah. And I doubt that many of you know the breadth and scope of the things that happen in these two organizations. And so we thought it would be a really informative opportunity for all of us to learn more about what they do. And I thought maybe if each of you could just take a couple minutes and introduce yourselves to the group. Tracy, you want to go first?
I guess I'm going first. Yeah, thanks, Scott, and thanks for your organization for always organizing such an amazing event that brings so many different sectors in health to a conference to learn so much about what's going on. As Scott said, I'm Tracy Gruber. I'm the Executive Director at the Utah Department of Health and Human Services. For those of you who don't know about our agency, we are the result of a merger of the Utah Department of Health and the Utah Department of Human Services that took place in July of 2022. And as the executive director, I have the great honor and privilege of overseeing this vast organization that serves across the lifespan in Utah, from really prenatal to death. It serves it not only incorporates Utah's public health system, but also Utah's human services system. And when the organization was being merged, we've talked about this merger at this conference actually before. There was a lot of confusion about the reasoning behind bringing our two organizations together. But I think this audience, more than any other, understands the relationship of between health and how people are living their lives, and things like tough economic conditions, growing up in poverty, experiencing maybe growing up in an abusive home or being the victim of abuse, and then what those long-term impacts have. And in our department, we have this great opportunity to address community health and well-being and see how that connects to health outcomes, to avoid having children and family, youth and adults end up in the deep end of the human services system. So the child welfare system, the juvenile justice system. And that's really what our organization is about, and our vision to ensure that all Utahns have fair and equitable opportunities to live safe and healthy lives. And we're working really hard every single day across our 6,200 staff from every corner of the state. So that's very, very high level, and I might have an opportunity to share more about our organization.
Yeah, we'll definitely want you to do that. Margaret.
Yeah, hi, thanks, Scott, and it's great to be up here with my colleague, Tracy Gruber. I'm the Executive Director of the Utah Department of Commerce, and you might be wondering, why is she here? This is not a conference I'm normally accustomed to attending, unlike Tracy. Tracy and I both serve in the cabinet of Governor Spencer Cox. A little bit about our department, then I'll get to a little bit more about why I'm here. So we're really the main business regulator for the state of Utah. We license about 500,000 people in our workforce. And we also house the consumer protection function for the state of Utah. We also house the business registration function in the state of Utah, or entity corporate registration. We house public utilities and regulating public utilities. So there's sort of a bunch of different things that we do. But of those 500,000 people that we license, so we license securities professionals, real estate professionals, cosmetologists, construction workers, 150,000 of them are healthcare workers. And so we think a lot about our workforce, and particularly of our healthcare workforce. So that's a little bit about our department and a little bit more why I'm here, and we'll talk later a little bit about the work that we're doing on the health care workforce piece.
Thank you for that. So part of what we're going to get into is some of the ways that they work together specifically and how that's really translating to a much better experience for all of us that work in healthcare here in the state of Utah. I wonder if you could just give a little bit more contour. I really do want you to take time and talk about your respective organizations. So things like you might touch on vision, size, scope, budget. I know you talked about the number of employees. Could you give a little bit more contour about that? And then one thing that I thought was really fascinating, particularly about DHHS, is that it really is addressing pretty much all the major populations. So whether it's youth or adolescents or adults, et cetera, that there's probably a touch point there for DHHS. And so could you just take a minute and kind of go where you want with it, but just I'd love to have people understand more of the contours of the organization.
I'm looking at my notes because I don't hold a lot of data in my head very well. But yeah, that's so. It is in fact our priority, and I'll talk about our various divisions and functions. And I'll just say that it does make sense that Margaret and I are up here together, apart from the fact that we all really, we like each other, and that's not uncommon amongst the various directors. But some of what we do in the department is also regulatory, but our regulatory scope is different from Commerce's scope. But there's so much overlap. So we do, as I mentioned, we have a very large budget. Our budget is over $8 billion, 8.65 in FY25, and $5 billion of that is federal. So you can imagine, if you're paying attention at all to the news, what is going on has direct impact on our department. And of that amount, we have about $6.45 billion of our $8 billion is for Medicaid. So in terms of where that money is going, we have a tendency to think, oh, this department is so incredibly large and the bureaucracy is so large. The reality is that our department has actually shrunk in size since 2007 by about 9%. The vast majority of our money is going to support Utahns across the lifespan through the Medicaid program, and about 46% of those members are children. Another fact that I think often gets misunderstood is that Medicaid is largely a program that's supporting individuals with disabilities and kids. So in terms of our department, we have 4 major sections. We at the cabinet level and across the state have a very serious focus on customer experience and customer service. So while I might be talking about our bureaucratic structure and the rationale for our structure, in terms of the public, I don't want the public to really have to worry about what our organizational structure is. If you can't come to our department and get good service from us, regardless of who you contact, then we're failing the public. But we do have 4 primary sections, one that focuses on our operations. So if you think about budget and legal and communications and contracting, finance, all of auditing, that's all in our operations section. We also have a clinical services section, which right now has the Office of the Medical Examiner. So we have 1 medical examiner in this state. Many states have multiple in like a coroner model. We have 1, and that's also where Correctional Health Services now is. So in 2023, we started overseeing the medical care for inmates in Utah's correctional system. And then we also have healthcare administration, which is where Medicaid is, the state hospital, which is the health facility for those with serious mental illness that's run by the state. There are private entities. And the Utah State Developmental Center, We oversee individuals with disabilities, so Division of Services for People with Disabilities. And we have another section called Community Health and Wellbeing, which is where our Division of Population Health is and Family Health, the Child Welfare System, again, recognizing that good health is tied to good outcomes for individuals, so we have those entities together, along with the juvenile justice system. If we can leverage the resources across the department, we feel fairly confident that we're going to move the needle and improve outcomes for children, youth, and families across the state. So we have several initiatives through our strategic plan that's focusing on access to high-quality health care, ensuring we have enough health providers throughout the state, and of course, making sure that we are a sound, high-quality department that builds trust in the state, which is so incredibly important, particularly at this time, still kind of coming out of the pandemic and realizing that in order for us to do our jobs, both on the public health side and the human services side, we have to have the trust of the public. When you think about removing a child from their home, which I would say is the most profound exercise of government authority known, you really have to have trust. People have to know that they can call our department when they're seeing abuse occurring or fearing that abuse is occurring, and know that we are going to act to protect those kids, and that if we remove a child from a home, we can be trusted to make that decision. And so when you don't have trust, our department really has an inability to really do its job effectively.
Thank you so much for describing that. I loved what you said about how really it's about how we interface with people and the service that we're providing to them and giving them access to services and how they feel about that. I loved your emphasis on that. And I didn't mean to overly focus on the details of the bureaucratic structure, except for that I think it's a really important for people to understand the scope and the size and the orientation of the services that you provide. And I think, anyway, I just love the way that you framed that up. Margaret.
Well, I won't go into all of the details of a lot of our department because it's completely irrelevant here, but I will just say a couple things in terms of how we interact, both on the enforcement level. So Tracy touched on this. They have regulatory authority typically over the healthcare entity, and we have over the actual licensee, so the individual healthcare worker. And so we're often coordinating on those kinds of things. In addition, I already mentioned a little bit, but on healthcare workforce. Where do we have shortages? What can we do to bolster that workforce? So that's kind of where we interact most commonly. And then a couple of things I did want to mention, because I'm going to get into it a little bit later, is one of the things that Governor Cox came in as being very important when he first came in for his first term, was to make sure that we were reducing unnecessary barriers for licensees. So not just in healthcare, but everywhere. He had a belief, which I think he's right, that in general we have too many requirements on our licensees that makes it harder to enter that profession. And so we, in response to that, decided to set up sort of a policy study office called the Office of Professional Licensure Review. Sounds really bureaucratic. We call it OPLR. And that we have just a stellar team assembled there that is looking at places where we need to revise our regulations. And I'll talk a little bit more about what we did on behavioral health in that vein. We also set up an Office of AI Policy just last year. And our first recommendation to the legislature came out for this past legislative session, and it had to do with mental health. And I'll talk about that a little bit more as well. AI is going to be everywhere in healthcare, and if not already is, and so we're thinking deeply about some of those things as well.
Okay, fantastic. Now, you mentioned, and this is kind of a segue to our next conversation, is how your two groups have interfaced. You mentioned some of the licensure issues that you've been working on, particularly with healthcare professionals. Would you both just dive into that and explain what that was? And I know we did that a little bit ago, and what the outcomes have been. Have we seen positive outcomes, or how would you describe what's come of that?
Which part, the behavioral
Sorry,
health stuff?
the licensure change.
Oh, the licensure change,
So
yeah.
and describe that process about how you identified that, why it was important to do it, and what the outcome of that was.
Yeah, and I'm happy to kind of go over this. I actually have a few slides I wanted to show you just to give you a very brief overview. So we decided to, in Opplers, that new office we set up to look at professional licensure, we decided first to look at the behavior health workforce. We license a bunch of different folks in behavioral health, psychologists, clinical mental health counselors, social workers, substance abuse workers, those folks. And we knew that we had a huge shortage of workers and that we were in the middle of a mental health crisis. Now, Tracy knows this better than anyone. I don't know if you want to speak to that before I get into that mental health crisis.
Only to say, I mean, we all, regardless if you're in the health field, I think we all have felt it at some point in our personal lives, if you're not actually working in this space, that there is something going on in terms of behavioral health, both with youth and adults, and increased during the pandemic and in the aftermath of the pandemic. And what's been so great about the partnership with the Department of Commerce on this piece is that before they really dove in, they spoke to our team at Substance Use and Mental Health quite a bit to kind of understand where the challenges were within the workforce. So it wasn't like, here's this department completely removed and only looking at the license itself in deciding in their infinite wisdom, of which they have a lot, that they're going to deal with it. They actually came to us and started with us and with other partners who are working in this space to try to figure out what was actually going on with the workforce. And that then launched into this more intensive analysis and plan to address the challenges in the behavioral health workforce that I think we're still trying to realize.
Yeah, and so if we can bring that slide back up, one of the first insights our team gained really from Tracy's folks in looking into this is that the structure of the behavioral health workforce is off. So if you think about on the right-hand side of your slide, you'll see the physical health workforce and the people, we have the fewest of the people that are most trained, right? And what that means is it's a much more efficient workforce because you can assign down tasks that to people that are less trained than you so that you can focus on the top of your scope of practice, of your training. And so what happens in the behavioral health workforce is we don't have that. We don't have what we call extenders. We don't have CNAs and LPNs and those types of folks that they're equivalent. And so we don't have that efficiency happening in behavioral health care in terms of the workforce. And of course, there's also not a career ladder either, which is also a problem. So just very briefly, one of the things that we recommended doing is actually filling out that sort of career ladder, if you will. And we created via legislation, in partnership obviously with the legislature, these two new levels of behavioral health workers. One is a one-year certificate of behavioral health technician, and another is a behavioral health coach, which is a bachelor's level. One of the interesting things we found is that psychology is the #1 undergraduate degree within our USHE system, and yet there's no clinical path. And guess what the #1 profession is for psychology graduates? Retail. Okay? So there's this huge missed opportunity. We have people that want to go into behavioral health. We have a need for behavioral health workers. We have people that are interested in it by the nature of their major choice, and yet we don't have a path. So that behavioral health coach would essentially create a clinical path for those in psychology. So right now we have institutions of higher ed that are implementing these programs so we can start training these workers. So doing this kind of, if healthcare providers, if behavioral health care providers were to actually implement this model of care using extenders, we can't make them implement it. We can change the licensing structure, we can get higher ed on board, but we can't make them change it. But we would estimate that the cost savings for treating somebody is between 30 to 60% less. That's a huge savings in a place where we have a massive shortage and massive crisis. So that just gives you a little bit of a sense of the type of work that we're doing in that office. And very quickly, what right now that office has just started a study. Last year they actually studied cosmetology, so very not relevant here. But this year they're starting a study on nurses, physician's assistants, and then some sort of OT, PTs, and then a handful of other licenses and license types. And I just wanted to quickly share with you some of the preliminary findings. It's all very preliminary, and we still have a lot of questions, but I thought you might be interested. If you want me to do that now, is that cool?
Go
Okay. So interestingly, we always are hearing about a nursing shortage. We did not find that in our preliminary look. This is just for the state of Utah. So license growth is well above population growth, interestingly as well, particularly among nurse practitioners and PAs. So there's been a big push to get those into the market. Now we're not looking at doctors this year. Next year will be doctors, dentists, and those types of folks. And we also are able to sustain overall sort of lower levels of healthcare providers just because we have generally a younger and healthier population. HRSA, which you probably know, kind of looks at healthcare workforce adequacy. They suggest that we do have adequate coverage levels except for LPNs, and we think that's more of a choice of providers to use CNAs instead of LPNs. So we kind of underutilize those. Rural areas rely proportionally more on LPNs and less on RNs, so they actually do use LPNs more. And distribution of resources is obviously a geographic challenge. We know that. I know you're going to talk about rural health later. So just interestingly, if you look at that line that says estimated adequacy, that sort of would be 100%. You can see where we are right now for these different professions and where we're projected to be in 2037. So we're actually spitting out a lot of healthcare workers right now in the state of Utah. We talked about this. We use fewer LPNs in other states. And then some of the other just questions that we're still asking, again, this is really based on just the last couple of months that we've been working on this, but where might there be particular shortages in geographics, in skills or geography? How can we better distribute workforce? What is the role of out-of-state licensees? Because we know that's happening too. We have a lot of licensees that are not in our state, but practice telehealth here. Are our educational and career advancement pathways sufficient? Even though we have an adequate workforce, do we still have licensing requirements that present unnecessary barriers? To what extent are scopes of practice aligned and reflect the top of the training that folks are getting? That's a big question, because if you think about it, doctors are the only ones that can naturally expand their scope of practice by discovering new ways of doing things. Nobody else can. That has to be a law change, right? So there's a lot of looking at that. And then do we need to update our form of oversight for the profession? So those are the things we're going to be looking at. I just wanted to give you a heads up on that. We'll likely have some kind of legislation that will come out of this, but we don't know yet what, because we're still kind of in the preliminary findings stage.
And all of this work is just, it's very unique to Utah that OPLR has been launched and they're looking at this. And in terms of our relationship with the Department of Commerce, because they're regulating the professions, they also have access to a lot of information about the workforce itself. And so we are a data-driven organization at the Department of Health and Human Services. And so in order for us to often know what's going on throughout the state with a particular field, partnering with the Department of Commerce through DOPL is incredibly important. And one of the things that we know to be the case, in order for us to serve the public, similar to me saying the public shouldn't know our internal bureaucracy, we also want to make sure that we're functioning to serve the public regardless of the boundaries of our agencies. And so if there's a need for us to have information about a profession, for like the Health Workforce Advisory Council, of which Commerce is a part of, we have these partnerships to get the data so that we can solve the issue together. And health workforce is one of the things that we work very closely on, and it is part of a new strategic plan that the governor announced called Built Here, which was released when he took office for his second term, and includes addressing the need for more providers throughout the state, and particularly in our rural communities. So we wouldn't be able to do that. We wouldn't have that analysis of the profession without the help of the help and partnership of the Department of Commerce. So the ability for us to work together to solve some of these challenges is kind of like the superpower, I think, of Utah, that we will come together, regardless of what the boundaries are, to try to solve some of these things. The other area that we spend a lot of time, besides workforce, focusing on, I'll just give by way of example. So I mentioned that we regulate facilities. We regulate health facilities. We also license health facilities. We also license child care providers and youth residential programs and homeless shelters. We regulate the facility itself. But if we have an issue in a facility and we have to potentially launch an investigation, it's not uncommon for in the background there to be an issue with a professional within that facility, a professional who Commerce regulates. And so we can take action against a facility if something's going wrong, but we can't take action against, let's say, a health professional or other type of professional that's in that facility. So we make referrals to Commerce and DOPL so that they can handle that piece. And we can ensure that at the end of the day, all of our regulation, regardless of who's doing it, is about ensuring the safety of the public and the people who are relying on either that health professional or in that facility. So that's just another area of partnership for us. The other thing that I would just mention in terms of our partnership, where I think I didn't realize this until I came into the department, was all of the coordination that took place during the pandemic. Again, we both regulate. DOPL had to make some pretty significant either waivers of rules or issue changes to rules in order to make access during that period of time easier. And so some of the regulations that are in place, when you have an emergency, you can't use them. You have to be able to have some flexibility to waive some of those or modify them slightly. And Commerce was a key partner in Utah's response during the pandemic.
That's awesome. So I thank you so much for walking us through that. I think that is an incredible example of how you're both proactively approaching a challenge, okay? And nationally, we know behavioral health has been a challenge across the nation and in Utah. And one of those big problems has been not enough resource to be able to address the challenge. And so approaching this in a creative fashion, a proactive fashion, where you can right some of those challenges that are artificially there to serve people, I think is very innovative and progressive. And so certainly want to applaud both of you for the way that has been approached, and certainly the outcomes that you're having, those are very promising. And I'm sure that as you get through this, you're probably going to find other things that, oh, hey, look what else we've learned, and here's some other areas we could look at. Now, I would be remiss if I didn't ask this group, because I know there's just broad interest about this topic, but AI, and what you mentioned this earlier, Margaret, I wonder, how do both of you think about that as far as how can that impact for good the areas that for which you have influence? How do you think about how to engage that topic?
I think I'd have less to say about this topic. But I will say that our department's very bullish on AI, which might be a surprise. And we're not bullish on it in terms of we're going to transform our entire department with AI. We work in a resource-constrained environment and have a lot of administrative tasks that are placed on our staff. I mentioned licensing, but we also in child welfare, lots and lots of reporting requirements. We will never use AI to replace our staff, but there are tools that we could have within the department to make those burdens less on our staff so that they can focus on the reason that they came to be public servants, which is serving the public. And so we are testing several pilots in our department, very minor, but all administratively based. Things that none of you would probably care about, but in terms of our administrative rules and policies, are we using the same definition across all of our administrative rules and policies and using AI for that? Looking at a licensing record of a facility over a 10, 15-year period and seeing where they're having no findings at all and saying, like, we're okay with those rules. We're pretty confident we don't have to look at those rules in every single year that we go out to monitor, but maybe these 10 over here, they constantly are showing up. So that's how we're using AI. I'm super excited about it. I'm also nervous, as I think many people are, but I think that as a department, if we aren't looking at utilizing and leveraging the tool of AI, we're creating more challenges for ourselves, but it's pretty small scale. Definitely looking into it and looking forward for that to free up capacity for our staff who are on the front line and serving the public.
And if I can get the slides up again, I'll show you one more slide. So our last legislative session, 2024. Okay, I'm going to move ahead. There we go. We created the Office of Artificial Intelligence Policy. And what this office does, it has two tasks. One is to make policy recommendations around critical AI issues to the legislature. And two is to actually offer companies regulatory mitigation for AI technologies. I won't talk about that, but what I do want to talk about was our first recommendation to the legislature was around the use of generative AI in the provision of mental health care, particularly around chatbots, okay? There's a lot of these chatbots out, so we did get a bill passed, the first in the nation to be dealing with this, and I think it's relevant to you for me to explain the regulatory framework that we kind of came up with, because the reality is these chatbots are potentially getting into not just low-level sort of advice, but actually things that are currently licensed by DOPL, our Division of Professional Licensing, that are currently within the scope of practice of a licensed mental health care counselor or social worker or whatever, right? And so what do? Does DOPL go after the unlicensed chatbot? Is the chatbot something that needs to be certified by the FDA as a medical device, right? There's this really interesting area where we don't really have a solution. And so what we decided to do was, first we said, the data that is now being entered into this chatbot is of the most sensitive you can think of, right? It's very personal data about, you and your spouse and problems you're having or problems you're having with somebody else or whatever it is, right? Very sensitive. And of course, generally, the business model of these types of platforms is to sell your data and monetize it. So we said, nope, you can't sell it, you can't share it. We also banned targeted ads because that felt really creepy to have targeted ads based on what you're putting into the chatbot. But finally, what we did is we created a scheme which allows companies to innovate in this space without being nervous that DOPL's going to come after it for not being licensed. We created what's called in law a safe harbor. So we said, if you are going to be in these spaces that are currently regulated as scopes of practice in the mental health care space, then DOPL will not go after you if you're doing a whole list of things, which basically have to do with constant red teaming your app and constantly looking and making sure it's safe in a number of different ways. And we think that's a good way to move forward. We want to encourage innovation, but also to think about how we deal with licensed professionals. Now, will we do something similar with doctors? I don't know. Probably not. But something maybe in like investment advisors, right? Maybe attorneys will go there to think about how, as generative AI gets into the spaces of licensed professionals, how is that handled from a policy standpoint, from a regulatory standpoint? So I wanted to just mention that because I think it's relevant to you all as you think about healthcare workforce, you think about AI coming in. Now we're also going to be looking at, one of our next sort of learning agendas is AI in healthcare, probably looking at the data there. So anyway, wanted to just make you aware of that happening, and that's all I have.
That's awesome. That is really amazing. And I don't know, I don't follow all the states, but I imagine a lot of other states are struggling with these things, maybe looking for federal guidance or otherwise to try to understand how do you introduce models like this? How do we embrace the technology? But as Tracy was saying, be really concerned about some of the parameters associated with privacy and other kinds of things. So that's really great to get that update. I was hoping we could get a minute just to ask some questions. I know we have a little bit of time before the next session starts. There's a little bit of a break. I think it's at 1 o'clock that we're starting for the next session. So I think we've got about 15 minutes. Is that okay? Am I going to get in trouble, Catherine, if we just allow people to ask a question? Okay. Does anybody have any questions about what we've discussed today that they'd like to ask? Yes?
Just following up on what you were saying about AI, is DAPO looking, like, again, my nonprofit is really in the mental health space. I think there's that fear about HIPAA and using AI and how do we protect privacy of the clients that we see, and like, where is that data going, out into the ecosystem? Are you talking or looking at any of that to advise in the health or mental health space?
Yeah, so in that bill that was passed, that we recommended, was to essentially make the data that is inputted there like HIPAA-like protected. Yeah.
Yes. Speak, project.
Trying to talk loud.
There you go.
Oh, even better. Thank you. Mark Greenwood, family medicine physician, just finished being president of the Utah Medical Association. As you're talking about the licensing, on the one hand, I love lowering bureaucratic barriers in government and allowing people to practice. And we have an access problem in our state, and we acknowledge that. On the other hand, licensing serves also to ensure quality, right? The barrier is a quality barrier. And so the tension here is that as you lower the barrier to perform medical services and create more access, you run the risk of doing so at the expense of quality. So how you do it, as in all things, is as important as what you do. And there are different ways to go about it. What you described here is increasing access but through training and skills, as opposed to regulation or legislation allowing people to do things under a license that they are not trained or skilled to do. So you run the risk by lowering the licensing bar of decreasing quality. So what you've described here is great in terms of creating new training paths and abilities for people to deliver services that are critically needed. I think my question or challenge is to encourage us to do it in a way that does not do so by just allowing people to do things that are not trained. Much of what OPLR has done is great. I will give an example, for instance, of what I'm talking about. When you allow psychologists who are not trained in pharmacology or prescribing to prescribe just by changing a regulation as opposed to training and competency. So I hope that we can accomplish both, that we can remove barriers and increase access, but do so through training, skills, and education, and not at the expense of quality for our patients.
Can I respond to that? So what I would say is the state's business when it regulates something is to do its best to ensure safety. Quality is a different thing. So we just went through our big cosmetology review and cosmetology licensing. When we license cosmetologists, are we guaranteeing that they're going to give me a great haircut? No. That would be silly for the state to be involved in that, right? We want to make sure that they are operating in a safe way. Now, in the medical and healthcare workforce, sometimes safety and quality can be interchangeable, right? But really, the state's business is in safety. If we start to make it about quality, then that's a different thing. Okay, great, yeah. And on your thing about the psychologist being able to prescribe, that was a recommendation from Oppler, only after having gone through a whole practicum. And we did that because we found that there was a massive shortage of prescribers in this space. So it would not be without training.
I would love to do more questions, but we need to wrap up. I'm being told, so I'm getting the boot here. But can you just join me in expressing our appreciation for Tracy and Margaret? Thank you so much for joining us today.